Welcome to ATCM, the Emergency Medicine channel. Shall we start?
Yes.
A 60-year-old male, known case of type 2 diabetes, recently diagnosed AML, status post chemotherapy, presented to the ER with fever and cough. On our initial 10-second assessment, patient was conscious, oriented and obeying commands. Coming to airway was patent, no hoarseness, no pooling of secretions. Breathing, respiratory rate of 25 per minute, saturation of 99% in room air. Coming to circulation, BP of 130/80, heart rate of 130 beats per minute. Coming to disability, GCS of 15/15, bilateral pupil equally reacting to right. Coming to exposure, temperature of 102 degree Fahrenheit, GRBS of 140 milligram per deciliter. Coming to adjuvants of primary survey, acid base pH showing 7.40, PCO2 of 38 and bicarb of 23. Lactate
is
7.40. Lactate of 2.0. CBC CRP showing HB of 8, total leukocyte count of 500 with neutrophil 17%.
the 500, 17% means it may be around 100. And less than 100.
Less than 100.
80 or something.
Okay. Platelet of 35,000. ECG was taken showing normal sinus rhythm. Chest X-ray was taken showing a non-homogeneous opacity in the right lower zone of lung. Coming to sample history, a 60-year-old male, known case.
When you are telling chest X-ray, right lower zone white opacity means what all things it can be?
Sir, it can be any infections that can cause consolidation.
It can be collapse. How do you differentiate consolidation and collapse in X-ray?
So one is by the tracheal shift.
This is a lower zone collapse or consolidation. Upper zone means tracheal shift can be there. Lower zone, how do you normally diagnose? It is very difficult in your IC or ER, but even then, when there is a white shadow in X-ray, it can be either collapse, it can be consolidation. So collapse, how it is different from consolidation? Collapse is a loss of lung volume in X-ray. So you can see the most important thing is rib space. If the rib space is narrow comparing to the opposite, so that is one of the sign of collapse. And heart shadow can move towards the right side. And these are the two things we should always see. Whenever we are seeing a white shadow in any patient, always think that there are two possibilities. One is it can be a consolidation. Second one, it can be a collapse. Okay, collapse means it's a loss of lung volume. So depending on that, we can see the finding like narrow rib spaces. Mediastinum may shift towards the lesion. Okay.
So bronchoscopy markings.
Bronchoscopy markings, if it is a consolidation, bronchial tree can be present, consolidation. Vascular marking will be absent in both.
Coming to sample history, a 60-year-old male, a known case of type 2 diabetes, recently diagnosed AML, given induction chemotherapy with cytarabine and daunorubicin, successful remission induction, and the hospital course was uneventful. Discharged post chemotherapy, presented to the ER on day 7 with fever and cough of 1 day duration. Fever was high grade, continuous, associated with chills, and there was associated productive cough with yellowish sputum. No history of any breathlessness, chest pain, orthopnea or PND. No history of any bleeding manifestations, loose stools, genitourinary discharges or mucositis. No history of any allergies. No history of any similar illness in the past. Coming to general examination, pallor was present. No icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Coming to systemic examination, respiratory system, upper respiratory tract normal, lower respiratory tract on auscultation showed right-sided crepes. Other systemic examination was within normal limits.
Okay. So what do you think, what is the action you will take as a ER physician?
So we diagnosed this as a case of febrile neutropenia, which is secondary to
so this patient has got neutropenia. This patient is having fever?
Yes, sir.
He is having fever. And X-ray shows there is a right-sided lung consolidation or collapse, whatever it is. Okay. So So your diagnosis febrile neutropenia. Okay. What is the problem in neutropenia? Why we are worried about neutropenia?
There are higher chance of getting infections because
They can get infection from anywhere, including in the hospital. So here patient is having fever, patient is having neutropenia, patient is having consolidation. So what are the common organisms which can produce fever or pneumonia in a case of neutropenia?
So most commonly gram-negative organisms, both gram-negative and gram-positive organisms have a higher chance.
So any pneumonia, gram-positive, gram-negative can occur. That is a different issue. But here, why we are worrying?
Because Pseudomonas aeruginosa.
Pseudomonas is the most important worry for a ER doctor or intensivist. So this can be Pseudomonas. This can be something else also. So it can be Pseudomonas. So we have to treat that. So how do you take care of this patient in ER?
First, we will go with the reverse isolation.
What is reverse isolation?
We are keeping the patient isolated from staff and other
Normally in chickenpox and all, we are isolating the patient like you or other patient should not get an infection from the patient. Here we are isolating the patient to avoid infection from the healthcare professional or other patients. So we have to reverse isolate the patient. So anyway, patient has to be in isolated area. The healthcare professional has to wear all type of gadgets like to avoid infection to the patient. Okay, like goggles, mask, apron, everything. Okay, then
proper hand hygiene for the staffs. And also unwanted cannulations, IV catheters, everything should be avoided.
Okay.
Then we need to start immediately the patient with antibiotics, that is within 1 hour.
Okay, so you have to start antibiotics, that we will discuss afterwards. How do you diagnose MRSA in this patient? What other ways you can see MRSA is present in our body?
Sir, an indwelling catheter.
Which is a common area where especially in healthcare professionals, nasal. So if we simple thing from nasal orifice, you can take a culture and send immediately. Anyway, we have to send blood culture for this patient. What are the how many samples we have to take in this patient blood culture?
2 sets.
Okay, this is the one condition where we don't compromise. We have to send blood culture. Routine pneumonia, even if you don't send, nothing will happen because the total culture positivity will be only 30%. But here we should know what is the organism. So we try to take maximum samples, like 2 sets in two different places, 2 different time. Okay, so you have to take blood culture. Then what else you have to look for in this patient? Oral cavity is very important. Oral ulcers are very common. Oral ulcers, candidiasis, both are common, but oral ulcers, what is the character of oral ulcer in this type of patients?
So it will be more pale due to less inflammatory process.
So it is a white lesion. Mostly it is a white lesion. That is because very less inflammatory cells in the body. Okay. So here you have a pneumonia. This patient is having neutropenia. How do you cover with your antibiotic? Pseudomonas you are suspecting. Okay.
We can go with either group of antibiotics, or we can combination with piperacillin and tazobactam.
Okay. Pseudomonas ideally piperacillin, tazobactam or meropenem or whatever it is. That higher antibiotics are required. If you are if the patient is not that affordable, what antibiotic you can select? Because all patients cannot afford piperacillin, tazobactam or meropenem. Sulfa group can cover, but commonly used drugs. Quinolones will help. Okay. If the patient is not affordable, quinolones can help, or ceftazidime can help. Ceftazidime is anti-pseudomonas cephalosporin, but that the action of ceftazidime is not like piperacillin, tazobactam. It is lesser comparing with piperacillin, tazobactam. Ideal antibiotic, like you told, it is piperacillin, tazobactam or above. There are some guidelines say that you have to give dual coverage. One is piperacillin, tazobactam. Other one can be your quinolones or tobramycin, or that is aminoglycoside. So the second antibiotics may be required in severe cases. What happened to this patient afterwards? So you have started piperacillin, tazobactam, and oxygenation was normal.
Yes,
Saturation was normal, but lactate was slightly high. Okay, how do you treat that lactate, high lactate?
We can
What may be the reason for high lactate?
infections.
Infection alone will produce will
Sepsis.
not produce. Either it has to go to septic and internal circulation is compromised, or because of lung lesion, hypoxemia might have produced this one, or the drug what he is taking for chemotherapy, that itself can sometimes produce mitochondrial dysfunction and lactate. But he is not in lactic acidosis. Why he may not be in lactic acidosis? Lactate is slightly high. He is tachypnic, no? So that can produce some carbon dioxide washout. It can go to alkalotic side. But only for 2, lactate is only 2. That normally it will not produce acidosis. Okay. What? How was the response of patient? What happened to the patient afterwards?
The samples, everything was sent, and the culture showed only gram-negative organism.
Okay.
And according to the sensitivity, proper antibiotics was started.
Okay.
And after 5 days of hospital stay,
What was the organism in that?
so E. coli.
E. coli. Okay. So always, most of the time, it is gram-negative organism which produces infection in a case of neutropenia. What other infections are common other than bacteria? So bacteria, commonest is gram-negative. In that, Pseudomonas is one of the dangerous. MRSA also can occur. What other organisms can produce problem in a neutropenic patient?
Staphylococcus epidermis.
Organism means bacteria is over. Bacteria mainly gram-negative. In that, Pseudomonas. Gram-positive, MRSA. These are two organisms we are worried. Okay. That we can start. What are the other organisms which can produce
Candidiasis or
fungi? One is fungi. So if the patient does not improve with your antibiotic, antifungals has to be started. Then
Parasitic infections.
which parasite?
Pneumocystis.
Cerevisiae. Okay. So most of the patients who is having neutropenia, they come with lung infection. You have to start sulfa drugs, Bactrim DS. Okay. How do this Pneumocystis carinii or Cerevisiae present? What is the presentation? How do it different from other type of lung infection?
Fever with brown color sputum.
Brown color. So more symptoms than signs. So patient will be severely symptomatic. Patient will have a severe hypoxemia. If you auscultate, you may not see anything. If you take an X-ray also, you may not see anything. But afterwards, it will become a ground glass opacity, like ARDS-like picture it can develop. So to prevent that, all newer guidelines say that if the patient is on chronically on any immunosuppressants or a patient is having neutropenia, better to add sulfa drugs like that is Bactrim DS to prevent this problem, Pneumocystis Cerevisiae pneumonia. What are the other problems?
viral infections.
Viral infections can come, COVID-19 or H1N1, that is possible. Then
Patient can go on to sepsis and further multi-organ dysfunction following.
these patients are taking doxorubicin, danorubicin, all these things. Many of these drugs can produce pericarditis, pericardial effusion, myocarditis, all these things. So, and whenever patient come with breathlessness, we have to always think that there is a possibility of cardiac involvement. Why this patient was not given colony stimulating factor? Was it given?
Yes, sir.
Okay.
Filagrastim was given.
It is given. Okay. Now, what was the response after that?
The patient improved.
Oh. Patient counts are improved?
Actually, filagrastim was given prior to the on the time of chemotherapy only, sir. After
on admission
he was not given.
But his counts improved?
Yes, sir. Counts improved.
Okay. Any other problem was there other than this infection?
No, sir. No other.
Okay. Patient is improved and discharged. Okay. Anything you want to add? Yes, in this case.
Sorry, ANC count we had to monitor, and neutrophil counts after the finding the absolute neutrophil count, we had to categorize the patient into severe sepsis, moderate or
severe neutropenia, mild, moderate, severe. Okay.
Neutropenia.
And the absolute neutropenia. This patient is having very low count. He is in absolute neutropenia. So that is all. When you have a patient who is having neutropenia without any reason. Here the neutropenia is anticipated by when we are giving this drug to completely suppress the bone marrow production, that is anticipated. Okay. So in this patient, most of the newer guidelines says that this patient should be started on Septran to prevent PCP infection. So that has to be done when we are discharging. Okay. Thank you. Reverse isolation he has already told. That is very important. As a ER physician, you should always try to isolate this type of patients to prevent infection from other patients. Okay. So that is done already. Okay. Thank you.
Thanks.